Let me orient also. There. Okay, so this is how the dura looks like. It's very thick, actually. Okay. It's very thick. It's about 2 bond papers thick, but tougher than bond paper, because you need a knife or a scissor to cut. You cannot cut it with your fingers. Paper you can. Okay. So you will need to orient yourself here, but I'll try to make it easy for you lang. Okay. Whenever you look at a dura, there is an outside surface where the blood vessels are prominent. Blood vessels are prominent. There, see? That's the outside. That's the outside. This is the inside. It's smooth. All right. So outside, blood vessels are prominent. Thank you, brother. One only. Okay, one only. Extra. And the inside is smooth. Okay. Next, you want to find out how you're looking at it, whether it's coming from the front or the behind. If you can touch it, for example, in the exam, okay, then you're going to look for this structure here. It's like a sight.
Wait.
You know what the sight is? Ang ginosar pala sa cutting rice? That kind of cutting structure, okay? So this is the side here. And this is going to be what divides your left and right brain? Falx cerebri. Oh, so this is the falx. And once you see that, once you see the entire structure of the falx, you know that's the anterior. Why? Because in the posterior or in the back part, you see this one. Okay? That's a tentorium.
Ay, shit pa. Nani mag-zoom.
That divides your cerebrum and your cerebellum. Okay? And this one, you will come across this name. You will see this coming from the bottom and coming from the back. You're going to see this letter inverted U structure formed by the tentorium. That is what you call the tentorial notch. Okay? Tentorial notch na siya. Okay. So when I look at the dura, what is important to me that you will probably use or that we will probably get in the exam or identify in the exam? One, of course, is this vessel here. Okay, so again, I'm going to show you in here under the microscope. This one. This is very prominent. See, it's about 2 millimeters thick. Okay, and it covers the entire surface. It branches and covers the entire surface, outside surface of the dura. That is your... Take a look at your whatever we can find there. Okay, one thing galing. You know how to make life easy in identifying structures? You want a hint? You want a hint? Okay. Do you want a hint on how to identify structures in neuroanatomy or any anatomy? Yes. Imagine yourself in the 1800s. How thick was the dictionary? Thick or thin? Thin. That means they only found little names to identify. Okay? So, when I say little names, they did not have the opportunity. They always just pick the most obvious name. Okay? So, they started with this one. What? They figured out that this vessel is supposed to supply the dura. What blood vessel supplies and not drains?
Artery.
Artery. You have already the first name. So what is this? Middle meningeal artery. Why is it middle? Where is it? It's in the middle. Okay? So it's a middle meningeal artery. Where did they get the meningeal? From the meninges.
Meningeal artery.
Right? Simple. Okay? So, they also like using their names. Because every time that there's a development, they want their names in the textbook. Right? Okay. So the next structure that I will show you is this one. Is it clear, no? This one? This one here?
Anduga black.
It looks like a berries, small berries. There, this one. There. What do you call small nodules? Granulations or granules. So, somebody decided to put his name. Paconia. So, it's a Paconian granulation. Okay? Another one is, because this one is also adherent to the underside, there, underside. Alright, this one. This one. There, underside. It's adherent to the arachnoid. So, it's related to this one. There. So, it's also called arachnoid granulations. Correct? Alright. Simple, no? Okay, so this is just the surface. Okay. So, when I see this one, again, whatever I'm telling you now is going to come out in the exam, huh? So make sure you know it. Okay. Okay, so
Bye-bye, Gi.
again the tentorium from the back. This one. Okay. But from the reason I'm pointing that is because on top of that, on the outside surface, are dark structures. Anybody know what these dark structures are? Dark structure. None? In the dura, this one drains blood from the brain. So this would be a sinus. Okay? So if this is a sinus, the first sinus that you're supposed to see is on the middle part, center. Okay? Right, left, center. What on the top? What do you call it name? Superior sagittal sinus. Alright? The superior sagittal sinus goes posteriorly, backwards, 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 until it goes to this area here. And then it will divide. Okay? From here, it will divide right and then left. What do you call that horizontal portion of that sinus? Transverse. Again, the name, transverse. Sagittal because it's along the middle part, the middle cut, and then transverse because it's on the orientation. Okay, my favorite test question is this middle part here, the meeting place. Joining point. Letter C. Confluence sinus. But my favorite name is the Latin name. Simple man. Wala? No name? So you came here blank? Torcula. Herophily. Torcula herophily. Alright? So those are the blood vessels that I look at here. Okay. That's done. Okay? So this is the dura. Okay? So hindi na kayo manun. You're not anymore ignorant. You know what the dura looks like. Right? Right. Okay. Like I said, before we start looking at the brain, we look at the skull. Okay?
Ouch.
This is more or less how it's supposed to look like. Okay? This is your calvarium. Okay? In the calvarium, you just notice that there are... What are these structures here?
Sutures.
Okay? So they join bones. Okay? They're joints. Okay? Attaching flat bones. What do you call the joints that don't move?
Synarthrosis. Synarthrosis. Synarthrosis.
Synarthrosis. Okay, so there are synarthrosis joints. Okay, so the frontal, the parietal, and the not here the
Occipital.
occipital. Okay, in neurosurgery we have other names because we can see this, but we cannot see this. We call this the subocciput. The suboccipital. Okay, so this one, and then okay, we look at the holes later, but not all, just the major ones because I can't even memorize them. Okay, so again, it's just what you need in clinical. Okay, so what's important here is, to me, aside from the bones on the outside, the sutures, on the inside, you see the impression of the middle meningeal artery. There. Okay, so that's the impression of the middle meningeal artery. Okay? And then you also see the impression for your paconian or your arachnoid granulations. Alright? So those are the two structures that are important inside. The calvarium. Okay? Here you see a bit more. Okay. So, why am I fascinated about this one? Because one of my most frequent cases is head trauma. Okay? Accidents. From a vehicular, a fall, a blow to the head. Okay? And I always get a question from the family member, Doctor, my daughter, my son, my husband was hit from behind. Why does he have injury to the front of his brain? What do you call that injury? Contra-coup. Okay? Contra-coup. Opposite side. Opposite blow. Contra. Okay? C-O-N-T-R-E C-O-U-X. Yeah. Contra-coup. C-O-U-P-E, I think. Contra-coup. Okay. So, contra-cous. Okay. Anyway, so, C-O-U-P. Contra-coup injury. Okay. So, the reason for that is, sorry, let me just, the underside first. You call this the underside of the skull. What is important here, the big structure you can see, is actually the foramen magnum. Okay? The foramen magnum is the hole where your spinal cord and your medulla end. Start. Okay? Medulla ends, spinal cord starts. And there are two structures here that hold the skull to your skeleton. Occipital condyle. This one. Okay? The two prominent bones anterior to your anterior part of the foramen magnum is the occipital condyle. Okay? It's also important for us because you can get a fracture there. Okay? You have so many holes here, but never mind. I only have several holes that I want to talk about. So the first thing why I get a lot of questions is because they don't see this part here. Okay? So do you see this bone here that looks like a wing?
Yes.
What bone would that be?
Spinal.
Sphenoid wing. Okay. So it's called the sphenoid wing. And if you notice, this part here, the roof of the orbit or the floor of the frontal fossa is smooth or rough? Smooth or rough?
Smooth.
You have bridges.
Charot.
You have bridges and mounds. This is smooth. So if you get the chance to hold the skull, run your finger across it, and you'll see there's a lot of bulges. And then here, basically smooth. Right? So the rough part is actually the reason why we get a lot of contusions. Because your brain moves in relation to the injury and it rubs itself on this part. And that's why even if you were hit here, you have a contusion in the front. Okay? Second reason you also have a contusion in the frontotemporal area is because you have the sharp edge of your sphenoid wing. Okay? So as the brain moves to and fro, you can cut the blood vessels in the sylvian fissure. Let me just show you the sylvian fissure. This one. This is your orientation, frontal, and then this is your sylvian fissure. The sphenoid wing enters through here. So as soon as it moves, it can cut. Okay? So that's one of the reason, another reason why. And of course, the last reason would be the temporal fossa. Okay, so we call it fossa. Anterior fossa, temporal fossa, posterior fossa. Okay? Again, anterior, temporal, posterior fossa. The posterior fossa, seldom do you get a contusion. It's also very smooth. Okay? Very smooth. Alright. Next. What structures are these? Is it better here? Okay, so this
Game.
okay. Okay, better? Can people see? No. Alright, so sphenoid wing. What do you call this structure here? Not yet? Anybody? Anterior what? In front. Anterior front. Oh. Anterior clinoid. C-L-I-N-O-I-D-S. Anterior clinoids. Okay? The reason why I'm pointing that out is because I like this structure all the time. When I do surgery, I have to remove that to reach the aneurysm. But aside from that, another case that I like doing is the pituitary tumors. Okay, so another case I like doing is the pituitary tumors. Okay, so cell phone likes ringing when you're busy. Sorry. I'll just call it. Okay. Okay. So when you deal with pituitary tumors, do you know already the complaint of a person with pituitary tumors? What visual field defect? Visual field defect do you see in patients with pituitary macroadenomas? Bitemporal hemianopsia. And therefore, in bitemporal hemianopsia, you start seeing the relationship of that tumor with the optic apparatus, which is your optic nerve and optic chiasm, correct? Tatlo lang nag-yes.
Yes.
Yes. So here you see a hole, medial. This is the clinoid, medial to the clinoid. You call that your optic canal. And if the optic canal, do you see a paper clip there? Paper clip or a probe? Sa likod nila. Paper clip or a probe sa windowsill. Okay, so this is your optic canal. See? So I can insert a needle through the hole and it goes out through here. Can you see? No. There, oh. Alright. So it goes out to the globe. There, orbit. Okay, so that's where your optic nerve goes through to get to the brain. Okay? Okay, great. Okay, so what is this hole supposed to be for? This one, this big cavity there. What is that supposed to be for? Cribriform plate. So that's where your tiny olfactory nerves, no, go through. The fine ones that go through there. And then this hard one in the middle is your, again there, there, this hard one, this one. This one. Okay. What is a high point in a mountain or a hill?
Peak.
C. Crest. Cristagalli. Okay? So it's a Cristagalli. That's your Cristagalli. Okay. Somebody mentioned okay, I don't know because this is 2D, difficult to show. I'm just going to have to do this. Okay. There is a hollow seat in this, from the anterior clinoid going back, there's a hollow seat. What would that seat name? What's the name of that seat? What is seat in Spanish? Spanish saddle. Turkish saddle. Okay? Turcica is Turkey. Okay? And then the cilia will be Turkish saddle. So that's a sella turcica. Okay? And that's where your pituitary gland rests. And then of course the one in the back, the one sa kung sa saddle niya, ano kanin? That would be your dorsum sella. Dorsum sella. Okay? This one. Okay? And then, going back,
Kapoy.
posteriorly, so you have anterior fossa, identify structures, Cristagalli, cribriform plate, okay? Your sphenoid wing,
Sphenoid wing.
yes. Your anterior clinoids, yes.
Optic
Optic
canal.
nerves, optic canal, yes. Sella turcica, dorsum sella. Okay? Next is going to be the back part. What do you call these ridges here? What bone is this? Letter P. Petrous bone. Okay?
Petrous.
So this is your petrous bone. And that's the rising, and that's supposed to be where your inner and middle ear rest, inside. Okay? But there is something here that I always point out also in the exam. And there's a big hole here that I can insert a needle. Sorry, here na lang. 2D. Okay, petrous bone. Alright? Anterior fossa, going down clinoids, dorsum sella, and then this one, this is your petrous bone. And there's supposed to be a cavity there, or a small hole, that I can insert this on left and right, this needle. Oh, sorry. Hindi siya kasulod maayos, I'm just going to hold it. This one. There. Anybody have an idea of what that hole is for? Pardon me? Louder, louder. So it's inside, so it's what? Internal auditory canal or meatus. Because this is the external auditory meatus. So this one is the external. Then of course there has to be an internal where your 7th and 8th nerve come out. Okay? Or go in, sorry, go in, to go out. So, why is it again important for us neurologists and neurosurgeons? Because this is where the origin of your CP angle tumor comes out. CP angle. Okay? So, cerebello-pontine angle. Acoustic schwannoma. Right? And then of course, your foramen magnum. Easy or easy?
Or.
You have recording, you can remember when we were in med school, we did not even have
Projector.
recorders. No projector. Oh, we had already. Nagkagak. Slide projector ba? That was what we had. Okay. So the skull is done. Okay. Okay. Any questions so far? Okay, but what I showed you is what I find very important. Okay? If you want to know more, just look at your book. I have this book that I follow. Ano siya dahil? Snell na? Hindi? No, there's another anatomy book that a live specimens also. Cadaver, sorry. Macmillan. Okay? Ang Macmillan is MC or MAC?
MC.
So how do you pronounce that? Macmillan. Okay? Irish na eh.
McDonald's.
You listen better to the kano. MC is what origin? Irish, Scottish, MC. Huh? So, Macmillan. Okay, huh? So, you can use that. That's a very good textbook. That's what I used when I was in med school. And I got 90s in my...
Wow. Kami man, be.
Nako, tingnan mo yun.
Oh, you heard the latest conversation? I said I used Macmillan, and then I got 90s in the exam. And this lady in front of me says, "Ako man tani." I wanted a 90. What do I do? Simple life. You want a difficult life? It's going to be like this.
Bye.
What's D? Nahiyaan ng Pinoy sa D. Oh, sorry. The Filipinos like D.
Ano nga D?
They always add D. Drama.
Drop.
I'm so busy, I have a family, I cannot study. My boyfriend called me up, I cannot study. Ay, nagiging kami gabi, bro, hindi ko ma-study. Always a D. Okay? So, if you want life to be easy, choose, another one, before we go forward. All our lives, bala, all our lives. If I say bala, it's not a bullet, huh? It's all our lives, okay, we were taught to do something different. Only lately that I realized that there's a different way to think. Okay, I call it my paradigm shift, my eye-openers. Because I treat my children that way. Okay. That's because that's how I was treated. All the time we were made to do the X. Study well, go to school, that's an X. Everything that you have to do is an X. Finish your course, go to med school, or get a job, earn a living. Nobody told me where I wanted to go. Correct? So that's why it's difficult for some of us to go, to do that, because actually we don't know where we are going, one, or we don't like the place where it is going, letting us go. Okay? Now, you have the choice, because you got it from me, to look at your result first, and look for the work that will get you there. So the person who is going to stay here, no matter what happens, just wants to become an MD. That's all. If you're here to earn money, you might be disappointed. Okay? If you're here to earn prestige, maybe you'll get disappointed. If you're here to help people, yes, sometimes you'll be disappointed. But if you're here just to put an MD under your after your name, this is where you're supposed to be. That's what's one of the strongest. Why do I say helping people is disappointing? Number one is you cannot help everyone. The worst thing is not everyone wants to be helped.
True.
Diba?
Ika.
You tell them, they go to you, they go to Corazon Locsin, this patient, ay, na lang na ka. Hindi na lang ko. He's not even going to die. Problem is, financial. So, you're going to waste so much time and effort to try to treat somebody who does not want to be treated in the first place or does not have the money to be treated. Okay? So, it's basically a vocation. Okay? So, you have a chance now to look at your result. Where do you really want to go? If you want to earn money, you don't have to be in med school. You want to have a life with your family, spend time without having to get called twice, 3 times a night. If you want to sleep straight, this is not the place to be. Because I haven't slept a straight night. I only get to sleep straight if I'm out of the country. I get called 3 to 4 times a night. Okay, so that's even lousy because they're just asking me what IV to follow. The patient has fever. The nurses don't even know to give fever medication. They need a neurosurgeon to answer. You have to give paracetamol. Sometimes it's okay, I can go back to sleep, but most of the time I cannot. So I end up sleeping an hour later, and then I wake up 6 an hour later. Okay, so you want to sleep? You love sleeping? This is not the place to be.
Bong.
Okay?
Bong.
That's the first thing that we're going to remove from you, sleep. Huh? Okay.
Babay Gi.
You want to have vacations with your family often? Not the place to be. Okay? You have a birthday party, you get called. So you leave your son with your wife, who's also supposed to be the doctor, and then, ako lang, anay, lakad. Just stay there for a while. I'll be back right away. Okay? Now the patient needs surgery, you lose another job because there's a party, your wife is supposed to be your partner, can't leave also. So you want time with your family, not a place to be. Okay? So many times, so many things, not the place to be. Okay? So, but if you like discomfort, you're a masochist,
Sakit.
you're a pessimist, you have to tell them, "Ano ka man imo yan na nasunod." So I hope you take care of them because this is for your next batch. Okay. So, of course, we look at the brain first in its entirety. Okay, so this is how the brain would look like if it were alive. But of course, the guy will not be alive now. Okay, so you have a top surface. The top surface shows the frontal, the parietal, and then when you just flip it a little bit, the occipital, and at the bottom, the cerebellum. It also has a side view, which shows you the frontal, temporal, parietal, and partly the occipital. Okay? It also shows you, if you look at it from the bottom, the inferior part. Okay? So you have your frontal, your temporal, you have some of the cranial nerves, okay? You have some of the major arteries, and then you have your brainstem. This one, this is your midbrain here. Of course, the medulla is stuck to the cerebellum part, okay? Because that's the medulla there in the middle, okay? And each of them, you have to identify the structure. Okay? So how do you know that? Again, by going to the orientation. From front to back, what are you supposed to see, etc. When you cut the brain, you can cut it in a sagittal way, where you cut through the hemisphere. We took out the cerebellum already, which is supposed to be here. Okay? And you see the medial part of the brain. And then again, you see several structures which are important. I'll just point them out so that you'll know where to start and looking for the structures. Okay? So this is the medial part. Okay? And of course, when you cut the when you want to see the brainstem, you're going to be cutting off the cerebellum. This is the cerebellum. Okay. So the cerebellum looks different. Even the structure looks, even the outside looks different because it has lines instead of gyri. There. Okay. And then of course this is part of your medulla. And then there's a blood vessel in the back. If we see that, okay, then that's if I'm not mistaken, that's your basilar artery. That one. Okay, basilar artery. How do you know an artery from a vein? You check the wall. The veins are usually bluish in color. The arteries are usually tougher and they have the same color as the brain. Okay, ang imong the veins are bluish and very flimsy. Okay, so that's a vein. So an example of a vein would be this one. Unfortunately, we have very lousy coloring here. That blue one there, that's a vein as compared to this one. Okay. In this specimen, we also have cranial nerves. Those fibers coming out of the medulla. There, those are cranial nerves. See, the vein is smaller.
Send ko lang sa group.
They're flimsy. The violet ones. Like this one is a flimsy vein. There. And this is a tough artery. Right? Okay. So this is how the cerebellum would look like as a whole. And this is the cross section of the the sagittal cut of the cerebellum. Okay? The inside part. In the inside part, you see the architecture of the cerebellum. What does the architecture remind you of? Leaves, right? Plant. What do you call the leaf of a plant? Okay, never mind. Let's go on a different. Okay. What types of fertilizing method do you know? Who has agriculture? There is one that you put in the soil, and what if you put in the leaf? Foliar.
Like manage.
Foliar. Okay, so this is what you call a foliar architecture.
Foliar. Spelling.
Okay, you have to know this because this is something different. You don't see this in the cerebrum. There. Okay, so let me start with this one first because I like looking this way. I'm here already. So this is what you call the foliar architecture. You can see that. Okay, and then of course there's something that's bulbous in front.
Identification.
Here na lang.
Identify. YouTube. Sige.
Alright. So this is the medial section of your cerebellar cut in our specimen. So you have something here that's big. That's your pons. And therefore this is your medulla. Okay? And then there's a cavity here that's diamond shaped actually. That's your fourth ventricle. Okay? So in this structure, in the specimens that we have here, these are the important structures that we usually try to identify. Okay? So you have your pons, medulla, foliar architecture, and then your fourth ventricle. Alright? Okay. Now sometimes This one looks ugly, but there are specimens there that have a very nice bulging near the medulla, like this one. Okay, there's something bulging here, and you can see that here, there. Alright? And it's coming from the cerebellum. It's the bottom part of the cerebellum. And there's something bulging here. And then I just spin it. Okay, so what would you call that structure? Cerebellar tonsil. Okay, so that's, if you look at it here, you orient yourself, it would be something that's bulbous, bulging, comes from the cerebellum, very near the medulla, and if it's in the skull, this would fit just right on top of the foramen magnum. Okay, I'm pointing this out because we have a lot of patients who have trauma to the cerebellum, tumors in the cerebellum, strokes in the cerebellum, and they die of one of two ways. They go into respiratory arrest mainly because of herniation. And what kind of herniation do you call where the tonsils try to insert itself in the foramen magnum? Nope. I just mentioned it. Tonsillar herniation. Okay? So let's see if we can okay. This is the orientation when the patient is supposed to be alive. You have your medulla coming out to this hole, and you have your tonsils on both sides of that medulla. If you have a tumor in the cerebellum, a bleed, swelling, it's going to push that tonsil through this hole. And because the medulla goes out through here also, let's try to see if we can, this one here, there. This one is going to press on the medulla from here. So it's going to strangle the medulla, like this. So you call that tonsillar herniation. The reason why you have respiratory arrest is because your respiratory center is in the medulla. Life is easy. Neurosurgery is easy. Huh? So, there's already one treatment. If there's a tumor in the cerebellum, the patient is going through tonsillar herniation, what do? Remove the tumor. Our life is very simple. We don't like to look at the pathway from the front nucleus to the back nucleus to the no. Just remove. Okay? We will take away the structure so that there's nothing to identify. Okay. Joke na tani, joke. Thank you. Hey. All right, let's move. Okay. First set after orienting yourself with how it looks like, you try to go now to a little bit more detail. Okay. So you see a lot of corrugations. What do you call them? Gyri. What do you call the sinking part of the So actually, the brain is just a big blob of curves or blind spots, whatever. No? They just turn. And the reason for that is if you did not put those curves where the top portion would be all cells, which are neurons, and it was just flat, your head siguro would be as big as maybe what, 4 feet diameter? Your head? Because it's going to be all flat. Okay? The reason why we have to fit this one in our head like this is because there are so many lines. Who's been to Disneyland or Enchanted Kingdom where you look, uy, the line is short, but when you get inside, it's 10 lines doing this way. Okay? Snaking from the back there to where the line is, and then it's 2 lines back. Okay, so that's what you see. That's how these things oriented. So again, you look at the front, the middle, and then the back. Okay. Next thing you're supposed to do after looking at the gyro and the sulci is look for the main sulci. 2 main sulci. What are they? Central sulcus of Rolando and Sylvia. I don't want to destroy this one. This is good. Central sulcus of Rolando or Rolandic suture or Sylvia and Sylvia. Okay? So this is how it would look on the side. This guy is 15, 16 years old already. Okay? So first I always look at the Sylvian. Why is that? It's the easiest to find. Because it divides what lobes? Frontal and the temporal. Okay? And therefore that's the one that crosses this one. And you can just open this one here, that's already your Sylvian. Okay. Who has, I know you don't have, maybe some of you have a why. Who plans on, and who came into medicine because they want to become a neurosurgeon? Beautiful. You have a why. Okay? So, MD, neurosurgeon. Good for you, because I only breezed through whatever, I didn't know what I wanted to do. Okay. So, when this is your Sylvian, the reason why this is a very important structure for us neurosurgeons is this is one way to get access into the middle of the brain. Circle of Willis, pituitary, uncus, inferior temporal lobe, hemorrhages in the thalamus, hemorrhages or tumors in the basal ganglia. We use this area. We use this slot. This is a natural slot. Okay? So you don't do much damage here because you're just splitting the arachnoid space. So this is the Sylvian. Now, the second reason why I also look at this first is because if you read your description, when you read the description, Rolandic suture, how do you locate or what is the location of your central sulcus of Rolando? One by one, one loud one. What are the ends of that sulcus na Rolando? Does it end in the posterior part of the Sylvian? Does it say? Parietal na butang? Okay. If you're going to look at other descriptions, the Rolandic suture, the Rolandia fissure, has 2 ends. It's supposed to go beyond the midline, and it's supposed to hit or meet your Sylvian. Okay? So if I follow this one, of course this is already broken. If I follow this one reaches all the way up to here. And the reason why this is broken is because we have to tease it off. Okay? And then if you follow your finger, it's really open all the way to the Sylvian. To the Sylvian. Is there another specimen there? Who has gloves in? Anyway, let's try if I can find it here. Okay. If I use this specimen, I'll tease off the arachnoid. This is arachnoid. See? I'm going to tease off the arachnoid, and I can open without destroying the brain. Okay? See, you see where I am now? I can see now the middle meningeal artery. There. So if I bring you closer, this is your sylvian fissure. There, that's your sylvian fissure. See, you can see blood vessels inside there. I hope you can see that. Oh, sorry, kanugon. Web-like structure. There. See? That's your sylvian. You see a lot of blood vessels inside there. There. Alright? Okay, so imagine what is a Latin term for spider? Imagine you being in the 1800s and trying to identify that web there. There, try to identify that web. Does it look like a web?
Yes.
So you're trying to identify what structure will I name that? Oh, it looks like a web. Ah, arachnoid. The dictionary is only very thin, so they can mention the arachnoid. Okay, so that's the sylvian in this specimen. Let's see if we can identify the right. So now,
Ano
I'll
ni-
try to see if we can identify.
Arm strength. Doon pa.
Right. So
Init.
the description for the Rolandic suture is that one end reaches the sylvian, and see there's this sulci here. Sorry, there's this sulci here that reaches all the way to the middle here, and then all the way to the sylvian. So I'm going to try to split that. And then go up, because I can see that it can reach there. You can see that there's a that it reaches all the way to the sylvian. Okay, so I'm just cutting it through and then see if it's a
Dumawag sa
sulci.
memory ko.
And it looks like a sulci. Okay, so it's a sulci. Again, this is sulci. Sulci. It has a turn for anteriorly. This one. Turn anteriorly, and then all the way through here. This is your Rolandic suture. There. I already identified it for you. Once you identify your sylvian and your Rolandic, you can identify most of your structures already. Alright? So there, it says there. Okay? So let's just go a little bit forward. And in the back, we have also your, what divides your parietal and your occipital. Sorry.
Occipital right.
Yeah, so that's what I like always. Just write down parieto-occipital sulcus, parieto-occipital fissure. If you want to be cocky, calcarine. I know more. I like it's calcarine. Okay. So that's it. Okay. So from there you can now identify. This is your frontal, parietal, temporal. Okay? So, because you have the sulci, you will notice that even if they say it's parietal, you have your pre-central gyrus. Okay? So, again, life is simple. They say, okay, what will we name this gyrus? It's in front of the central sulcus. So it's pre-central. So what do you name the one behind? You're so bright. Okay? You're so bright. Okay, so that's one. Okay, so now we know those two gyri. We now look at this set. What do you call this set? What lobe? Okay, when you say lobe, it's the entire thing. What do you call this? Frontal. Frontal lobe. Okay? So frontal lobe, you also see a lot of gyri, right? Okay? So they have to name that. Otherwise, they won't get paid. So they have to name that. So what they say was, Pare, there's so many lobes, what can we name it? How many do you see? 3 major ones. Oh, wow, great. So let's make it easy for us to remember because we might forget. They usually drink it before doing this one. So they've got so many whiskey already or their beers or they're drunk and then, oh, let's take it, it's open, okay, it's open. Okay, so they say, 3. So what's the easiest?
Superior.
I mean,
Inferior.
They get paid now $1. Superior, middle, and inferior gyrus. Easy or easy?
Easy.
Hey. So they want to test their theory that it's easy to name a structure. Pare, open the temporal lobe. Oh, see, sure, I'll open the temporal lobe. Where's the Sylvian? Oh, here, Dr. Martinez, opened already. Okay, great. So how many lobes are there in the temporal lobe? Lobules or gyri. 3.
Superior, middle, inferior.
They get paid $2. Life is simple. Okay? And then of course, in the back, occipital.
Hospital.
So we're done. Shit, so fast. But you can identify there. See, they're so excited even outside. Okay, so the next, of course, the surface of the brain outside is fairly easy. I usually ask lobes of the brain, specific gyrus, specific sulci. Simple. Okay. The one in the bottom is a little more tedious. Okay. Because there are more structures at the base of the brain. Okay. Maybe we can use this one. Okay. Let's test out their theory. Okay. So, when the scientists decided to look at the bottom of the brain, Ronald cut the portion and pull it out. Doctor, something at the bottom. Looks nice. Great. Okay. So they see this ribbon-like structure. What is this? Olfactory. No, like this long one. This one, ribbon like this one. Oh, nerve. The entire thing is the olfactory nerve. Okay? This bulbous structure is the olfactory bulb. And this is the olfactory tract. But the whole thing is the olfactory nerve. Okay. So they said, Okay? Dr. Tulmo, what do we name the structure here? What kind of lobe or what gyrus would this be? What did Dr. Tulmo say?
Din.
It looks funny to say frontal lobe gyrus. Yeah, it looks funny. All right. Okay. Sounds funny. And then something dropped. Boom. The skull dropped. Okay, when it dropped, it fell on its top side. And he said, "Shit, look at that." This is where that structure you want me to identify sits on. Yeah, correct. So,
Spinal.
how do we name that? Let's make it a little bit harder for them to know. Okay? Because I'm Dr. Tulmo, I want it hard. Okay. Okay, so it says, okay. Because you cannot see the brain not all the time with the skull, maybe we can name it from outside the skull. So, he sees this one. What is this? What's that? The orbit. And therefore, this is the roof of the orbit. And since that's the roof of the orbit, he decided to call it the orbital gyrus.
Oh my God. Orbital gyrus.
So it's easy. No, there just has to be drama.
Orbital.
Okay? So this is the orbital gyrus. This one. This one. Oh, sorry. Orbital gyrus, the flat part that sits on the roof of the orbit. But then, they name this one if you're going to use your imagination. This one. Here, huh? From here, straight down to here. Gyrus rectus. Why do you think they named it gyrus rectus? Straight from front to back. How liquidated their words, no? Oh, see? It's easy. Okay. So, you're now done with all the frontal lobes. Great or great? Great more? Ah. Okay. So, don't add D, you might not pass. Okay. I am going to move to this one because it shows a clearer picture. Okay? Okay. Okay. So, this one, the next structure that I will point out is supposed to be your Sylvian fissure. Okay. So therefore, it's in the temporal lobe. Okay. It's found on the medial aspect. This one, medial aspect. And if I'm going to draw try to use your imagination, please. Because that's what they did. They just used their imagination after drinking maybe two bottles of whiskey. Single malt because they don't use to blend. Okay. So, who likes playing chess? You play chess? Oh, you're Jana? Oh, hello. Who likes playing chess?
Din.
Ano yung siya pre, oh? Anong churas niya? Ito dito pre, hindi matanaw diyan.
A horse?
A horse! He's really a chess player. Sakto pre?
He likes horses.
Okay, you like horses, huh? Okay. So, what do you call a horse in Latin? San Lazaro Hippodromo. Hippocampal gyrus. Nice? You're supposed to say, ah. Great. Okay. So, the head of the horse has a snout. That snout is called the uncus. Okay? So, if this is your hippocampal gyrus, what would you call the back, the side part of your hippocampal gyrus? Para-hippocampal gyrus. They don't have anything to put. They find it so difficult to add more names. So para is just off. Para-sagittal, off. A little off. Okay? So para-sagittal, para-hippocampal gyrus. So you already have 5 lobes. 5 gyri. Superior, middle, inferior, hippocampal, para-hippocampal gyrus. Tapos ng temporal lobe. It's so easy, my goodness gracious. Okay. Another structure in the medial part which will aid you in identifying the other structures would be this big bulb here. What do you call that? Thalamus. Of course, I don't know where the hypothalamus is because guba na guro here. Yep, that's the thalamus. Okay? So, the thalamus has a hole here, which you call the... It's a space, pare. There, that's the one. No. Picture there. Yeah, that was the space there. That whole space. Cavity of the... Anyway, that's your lateral ventricle. Huh? That's your lateral ventricle. This is your lateral ventricle. And your lateral ventricle is bounded by inferiorly by your thalamus and superiorly by your corpus callosum. So again, it looks different. See, it's a different structure. It's like, the reason for that is because the fibers are facing us here. So it looks different. Sa aton siya katubang. Okay? It points to us. Okay? And then, what do you call this gyrus here? Cingulate. I don't know why cingul means in Latin. Cingulate. Single gyrus, maybe? Okay? Cingulate gyrus here. So cingulate, corpus callosum, thalamus, and the cavity of your lateral ventricle. Okay? And then, of course, you have your uncus here, your hippocampal gyrus, para-hippocampal gyrus here, inferior temporal here. Okay, so there. Inferior temporal here. Occipital lobe here, calcarine or parieto-occipital suture. You're basically done. Wow, so fast. Right. And then, okay. Can you pass me the specimen with specimen tray? Specimen tray.
Doon flashable.
Doon flashable.
Also showing. So you will have to orient yourself first. Okay, so what? The cell phone is becoming hot. Okay, so you will have to orient yourself first. So again, you see this one here. What structure is this? Olfactory. Therefore, you know that that's what part of the brain? Front part or anterior. That means this one is pointing anterior, this one is pointing posterior. You can see again this one here. Snout. So you see your hippocampal gyrus, the uncus, right? Okay, inferior frontal, inferior temporal. Okay? So when you see this bottom, you know that it's the bottom of the brain. So, there is a structure here actually, na nautod na, that's been cut already. And there's supposed to be a structure from here. And then here. Okay, and that would be what? The optic nerve. So, if that's supposed to be the part of the optic nerve, therefore, this one, the joining of those structures would be what? Optic chiasm. Okay, so, great. So, the next one is going back. You see this heart-shaped structure here. What would that be? What would this be? Midbrain. Okay? So why do you know it's the midbrain? Because of this structure here. Cerebral aqueduct. Okay? So you identified again two structures. Okay? So that's the midbrain
Brain.
and that's the cerebral aqueduct. Okay, so now what is behind the midbrain here that looks like two bulbs? Superior colliculus. There. There. Alright? So the colliculus is facing posterior. So, but you can see something anterior. This one. This one. Yeah, so can you see how green those guys were before, no?
Okay.
After drinking, reaching this part, they've already probably drank 3 bottles of whiskey. So they're now looking for a name. And then maybe his name was Dr. Jekyll. So he said, oh, am I not supposed to be Jack the Ripper? So I'll name this Mammillary Body. Huh? Dr. Jekyll and Mr. Hyde? Or Dr. Hyde and Mr. Jekyll? Okay. So that's it. This one here. Okay. So, the only thing left na lang to find out are the blood vessels. Okay. We will not be complete without blood vessel because we enjoy that job of identifying blood vessels in the brain.
Not me.
But the reason why this has to be shown
Ginautod-utod ko gani para dasig ma-upload kay if tingbon mo continuous hindi gidya may sobra ko 10 dapat di 5 8 mga mamo lang na
God, and that's the guy who made us. Okay? If you don't believe in God, and you think about the evolution, can you imagine the evolution that took place for millions of years before we came about? Okay? So that's the first thing. The second thing is the spinal cord. Okay, one of the shortcomings or pitfalls. One of the pitfalls in neurologic diagnosis is determining the level of the spinal cord. Meaning, I get because they don't seem to understand or grasp the there's this the theories or concept of the length of the spinal cord, okay, they do not understand it. It doesn't have to be by heart. Common sense, okay, that we get a lot of misdiagnosis in the clinics. Okay, so two ways to help us diagnose spinal cord problems or neurologic problems that include spinal cord is the cross-sectional anatomy of the cord, which is going to give us certain syndromes, and then the length, the anatomic length of the spinal cord, which gives us the level of the problem. Okay, but before we go there, okay, so let's review maybe 10 minutes from last meeting's topic. Okay, so how many lobes are there in the brain? Okay, can you name them, please? Okay, so by looking at that, you see how many surfaces, more or less, in the brain. How many surfaces do you see, or that you can name by looking at the gross anatomy of the brain as a whole? So you have superior, right? Because that gives you the interhemispheric fissure, as well as the frontal, the parietal, and the occipital lobes, right? How about, what's the other one? You have lateral. Okay, so in the lateral, you're supposed to see the temporal, the occipital, the frontal, and still the parietal, some of it. Then you cut it in the midline, which is the interhemispheric fissure, and you see that, that's the medial surface. And what do you see there mostly? You see the corpus callosum? No, the lateral, that's the lateral. Silvial and central sulcus is going to be on the lateral. When you cut it in the middle, you see the corpus callosum, cingulate gyrus, the thalamus, and the lateral ventricle. Okay, you can also see the parieto-occipital suture as well as the occipital tail. Okay, so how many gyri are there in the frontal? 3 on the superior surface, okay? You name them as superior, middle, inferior. Temporal. 3. Superior, middle, inferior. How many sulci do you see? 2. Separating the frontal, parietal, and temporal. What do you name that? Sylvian, correct? How about that separates the frontal from the parietal? Central sulcus of Rolando. Okay. On the bottom part, what do we see from front to back? From front to back, or from anterior to posterior? You see the olfactory nerve? Okay, you see the optic nerve in the chiasm. You see the internal carotid arteries, okay? The mammillary bodies, okay? The colliculi. Okay, so we go back to the front again. So we're going to look at the brain structure. You see the gyrus rectus. Where do you find the gyrus rectus? What covers it? What covers it in the anatomy? The olfactory. You have to move it to the side so that you can see the gyrus rectus. Okay, because it's running, covering it. Okay. How about to the lateral side? What gyrus do you see on the lateral side? Lateral side of the gyrus rectus. When you say lateral, to the side. Because the gyrus rectus is found in the medial portion of the frontal base. What do you see? It's large, triangular. No. It lies on top of the orbit. Orbital gyrus. The orbital gyrus, that's the flat part that looks that has a cavity that looks like a small cavity. Okay? Going back, on the inferior surface of the temporal lobe, what do you see? The snout of the horse. The hippocampal gyrus is supposed to be the whole, the horse, the neck, and the tail. But what do you see the snout? The uncus. Okay, that's the structure that is protruding into the tentorial notch. Okay, so that's the uncus. Okay, so how about the circle of Willis? What is the two main contributories of the circle of Willis? The basilar, internal carotid. The terminal branches of the internal carotid. ACA, what's the complete name of the ACA? Cerebral artery. Okay? How about the MCA? What is the complete name? Middle cerebral artery. What is the terminal branch of the basilar artery? The signal that goes to T8 here came from T9 or 10 and below. Right? So, if I put a pinprick here, if I put the, if the signal goes here, it goes up to my, let's say, T8, there are fibers that will cross to the other side and go up to the same side of the brain. Because this one goes to the brain, alright? Going up goes to the brain. Okay. So, Brown's cord has a characteristic. Okay? That's also why we study the cross section. When you have a problem here, what are you going to see after T8? Okay? So, if this is corticospinal tract from T8 going down, from the bottom of my rib down to my leg, let's say I get a stab wound here, what's going to be paralyzed? My left leg or my right leg?
Right.
Leg. Left. This dorsal. Left. Alright? So that's my left leg. Okay? But then, you're going to test for dermatome levels, correct? You're going to test, okay, so, you're going to find out what if he can feel or not. Sorry. Kulang. What's knocking? What does the spinal cord subserve? Before we go this far. It conducts electricity from the brain to your leg for what? Movement. Motor, correct? It conducts electricity or impulses from your bottom, from your skin, up to your brain. So sensory, correct? It also subserves. If you notice, I'm not saying it originates from there. It just subserves. Okay? It just allows the cord to go down, the impulse to go down or to go up. Okay? The other one is from the back. So you have posterior column, which is vibration and proprioception. Okay? And the last is supposed to be bladder and bowel. Okay? Signal for you to have bladder and bowel functioning well is also to the spinal cord. Okay? So, we will just talk about those two functions, which is subserving motor impulses and sensory impulses. Okay? So, in Brown's cord, okay, when you get hit on the left, let's say this one is spared, this one is okay, this one is injured. Okay. So, like I said, your corticospinal tract from the brain always stays on the other side, okay, on the same side. Okay? But the pain crosses. Okay? The pain crosses from the bottom segments, it crosses to the upper segment and then goes up. Okay? So, for example, I get hit here, then I don't have muscle power on my leg. Same side. Okay? But since you're a neurologist or a You like neurology, so you want to find out what other syndromes that patient has. Because why is his other leg moving? Correct? This one is not moving, yet this one is moving. So you're figuring out, is this a brain problem or a spinal cord problem? Okay? So now you want to find out if it's a spinal cord problem by identifying a dermatomal level. Okay? So the guy comes in, Doc, I cannot move my leg. Left or right? Just the left. This one is a little weak, but I can still move it. But the other one is paralyzed. Okay? Then it tells you, I also have numbness. So now you identify the pain, and at the level of T8, from T4 or T1 all the way down to T6, T7, everything is normal. Pinprick is normal. Okay, pin here, okay, yes doctor, yes here doctor, T6 normal. But on T8, everything is normal. Okay, below T8, you notice that there is numbness at T9, but T10 again going down, everything is normal. Here, from T9 going down, everything is absent. So you're figuring, why is the other side involved? Okay? You can only identify that one if you know the spinal cord anatomy. Correct? Why? Because corticospinal tract, so that's why Brown and Sequard probably studied this for years. I'm not expecting you to learn now. Okay? They were anatomists probably for years. But they discovered that the corticospinal tract, from the top all the way down, stays on the same side. But the signal coming from the bottom, okay, 1 or 2 levels, crosses this structure here, and then goes up on this level, okay, on the left side. So anything below here